Welcome back to the Parasitology lecture series. The point of this lecture is to discuss anti-malarial treatment. Let's begin. Before we leave this very toxic slide, here are some other important summary points. Let's clean this up first. Artemisinin anti-malarial drugs such as artemether, artesunate, and dihydroartemisinin affects Plasmodium species through free radical formation. They also affect the same life cycle stages, and it would be nice if you can clump them all together as artemisinin class of drugs. Drugs belonging to the quinine family, including chloroquine, piperaquine, mefloquine, and of course quinine, and also amodiaquine before I forget, all belong to the quinine family, and all of these interfere with the heme detoxification process. Primaquine is a very special exception to the rule. Please take note also that quinines, including primaquine, is contraindicated in patients with G6PD deficiency. So you need to test your patients first for G6PD deficiency before you give them quinines and primaquine. Otherwise, you might encounter blackening of the urine called your black water fever. Here are a few other malarial treatment guides. In treating malaria, you have to take note of three important factors: the Plasmodium species, the patient status, and drug susceptibility. Under Plasmodium species, you have to take note that Plasmodium falciparum generally creates a rapid and severe symptomatology profile. You also need to remember that Plasmodium vivax and Plasmodium ovale have hypnozoites which can remain dormant for months or even years. And some species of Plasmodium, particularly falciparum and vivax, have very specific resistance patterns. You should also take note that uncomplicated malaria, as much as possible, should be treated with oral treatment, while severe malaria should receive parenteral treatment and should be taken and cared for inside the hospital setting. Drug susceptibility of specific species, particularly in specific geographical locations on Earth, should also be understood. If you do not know whether a species is endemic in a particular area, always assume that it is the worst species, which is Plasmodium falciparum. Here is a distribution of chloroquine resistance versus chloroquine sensitive areas versus chloroquine and mefloquine resistant areas. Chloroquine resistant areas are these light blue ones. Chloroquine sensitive areas, meaning areas you can still use chloroquine on, would be these violet areas. While a few areas of the world have been found to be chloroquine and mefloquine resistant already. Take note that the Philippines is primarily a chloroquine resistant country. Therefore, we don't use chloroquine as first-line treatment anymore. Here in the Philippines, you have to understand that based on Administrative Order 2009-0001, under the revised policy and guidelines on the diagnosis and treatment for malaria, our first line of treatment for unconfirmed malaria, meaning we don't know the species yet, would be artemether lumefantrine combination drug. First line of treatment for confirmed falciparum infections would be your artemether lumefantrine plus primaquine to kill the gametocyte and prevent further transmission. For treatment failures, you give these drugs. You have your quinines plus your secondary line of drugs, clindamycin, doxycycline, and tetracycline. For severe malaria, you give your quinines and also these three antimicrobials. For confirmed Vivax infections, you can give chloroquine plus Primaquine, but in an extended dose. As a special added note, as we mentioned earlier, you can give sulfadoxine pyrimethamine as intermittent preventive therapy in pregnancy. This means that it is the treatment for pregnant women in their first or second trimester of pregnancy as part of antenatal care. Dosing should start in the second trimester, and doses should be given at least 1 month apart with the objective of ensuring that at least all 3 doses are received. Lastly, the strategy for treating malaria is through the observance of the directly observed treatment strategy, meaning the doctors should directly observe the ingestion or the administration of anti-malarial drugs, much like the strategy used in tuberculosis treatment. This is to ensure number 1, compliance for treatment, and number 2, prevention of anti-malarial drug resistance. And that is all what I can say about anti-malarial treatment. I hope you learned something from this messy discussion. See you on my next video. If you learned something, feel free to share this video. And don't stop learning.